You will not
It's a pleasure to introduce three speakers today. Novak, consultant in emergency medicine and ambulatory care here. Lois Brand, Associate Director of Clinical Studies and consultant in emergency medicine, and Phil Hormbrey, who's consultant in emergency medicine. So I'll hand over to them. Thanks very much.
Thanks very much. So I'm Novak of the three, and Lois and Phil here, and we're all consultants here in AUH. It's quite nice to see a few familiar faces here, actually. I don't look back. That we work with already, and we're in the process of going through something of a renaissance at the moment in developing our academic and our sort of innovative and portfolio of projects. And some of the things that have come up, particularly around imaging in the emergency department, our relationship with radiology and our clinical pathways. And this is what I really want to talk to you about today. So this is going to be, I'll give you a bit of background and context, and that'll sort of flesh out some of the ideas. And then really what this is a brief portfolio of 4 distinct projects, but all have similar themes running through them. And that just reflects some of the ways in which we're trying to develop our approach to imaging in the acute care pathways. Phil, I will hand over to fairly shortly, and he'll take some questions early. He has to go and stem the tide at the front door in a minute, so we'll try and get through. So really the context of this is that the economics of acute healthcare is just going through this rapid flux at the moment, and I think this is no surprise to anybody in the room. But there's tremendous pressure on the front door services, which is steadily rising, a good sort of 10-15% increase year on year in attendances. And as everyone knows, the hospital is just fit to burst. We've got low bed space, and that creates a tremendous pressure, and it puts particularly on the clinical staff, the time and attention of clinicians is just becoming this incredibly precious resource. And equally, while this is going on, our sort of key diagnostic tests of imaging, this one of our key resources, the costs are trimming down. They're becoming more accessible, generally becoming cheaper. The technology is becoming cheaper. And this is leading to a big shift in cost benefit towards pushing some of these tests, which are previously fairly ring-fenced into the specialties and into inpatient care, but actually pushing closer to the front door. One of the movements that you guys may be aware of is same-day emergency care, and this is a big drive by NHS England at the moment, covering every specialty, and pretty much every specialty in the hospital is responding to this at the moment. And this is the idea, perhaps, that there's a tangible sort of health economic benefit in getting people through the diagnostic pathway and their care pathway quickly, so within a sort of 24-hour period. And that, of course, is no news to A&E doctors. We discharge about 70-80% of our patients anyway. But the idea is perhaps tying some of the longer care pathways together and trying to see if we can get people through the whole process and get them sort of physically out of the hospital in that time. And all this as well is set at a backdrop of technological change. So machine learning has big implications for imaging. We have a big centre here, which I'll talk about in a second, the NCME. And this really sort of extends the potential for the capabilities of imaging into new diagnostic domains, and also the capabilities of auto-reporting or sort of automated reporting, and a way of processing large volumes of images quickly and directing clinicians. So, and this has been articulated by John Bell, actually, in the Life Sciences Industrial Strategy, and he really sort of sets digital imaging and this processed streamlined care as one of the sort of key themes in that. And this leads us neatly onto the NCME, which is an Oxford-led partnership. The idea of tying between the clinical, academic, industry and all patient groups all together and fitting a sort of streamlined pipeline for innovation. So developing AI tools, also getting them out into practice and into commerce. And this was really a direct response. In fact, it was a result of a large grant that came as part of the life sciences strategy. This is, as I said, it's led in Oxford, and you can see this is a cluster of the various sort of spin-off companies and products and academic partners. But actually the network is right the way through the nation, and that's a fabric of this. This is something happening everywhere, not just in an isolated here. So that gives you the sort of context and drivers of why we thought it was important to come and talk to imaging. All these particular sort of exemplar projects have got a sort of surgical leaning to it. You may be wondering why I'm talking to surgeons about the imaging within the ED, but all of these are sort of surgical pathways. And so what I'll do is hand over to Phil, if that's right. He's one of our early success stories for MRIs in wrist injuries.
Thank you very much, Alex. I'm starting with the very simple, and I'm going to talk about something that some of you may have seen in sometime in your career, scaphoid injuries, which is it's an interesting little topic for ED because it sounds a very trivial injury, but yet it's one of the very few minor injuries that cause serious problems if we don't identify it. It's a hard injury to identify. And this is the paradigm that I've tried to break. This happens still in most emergency departments across the country. You come in with a little bit of wrist soreness, you're put in a plaster for 10 or 14 days, and then someone else comes and looks at you. Now, why has this happened? Well, it's happened for two reasons, primarily. It's happened because the thickest has been seeing the sickest. That's the old talk. And that's unfair, but it's actually untrained people, i.e. very junior SHOs, or whatever we call them now, in their first few months of training, traditionally have seen this group of patients. And they're not by no means the thickest, they're just not trained. So we've been having totally the wrong group of people seeing this group of patients. And because of that, we then had to make sure that they got an expert review, which the decision was generally, for other reasons, I'll go on to, that was at 14 days. The second reason, actually, the investigation that we do to look for this injury is not very good, and I'll come back to that. So in most departments, just to manage this horrible flow that Alex has talked about, what happened was it said that any patient with any sort of vague form of wrist injury, and it was probably something totally different from a scaphoid injury, got stuck in a plaster, immobilised for 14 days, taken out of work, taken out of tax status or whatever, and then came back 14 days later to be reviewed in an ED clinic and a fracture clinic. Enormous cost to society, enormous cost to a lot of people. Quite a few patients actually got quite used to this and actually knew, well, if I just fall on my wrist, I'll go to the emergency department, I'll get put in a plaster, and I'll have 2 weeks off work. So not a good treatment. In Oxford, Oxford's always a bit different, isn't it? And Oxford was very different here. So many of you will remember 25 years ago, Peter Warlock and Keith Willett designed this trauma service. And the trauma service, one of the things was every patient with a fracture would be reviewed the next day. So there was an expert review the following day, which got rid of a few of the patients because they identified that there was some other injuries in there. But still, there were so many coming back 2 weeks later for a later examination. So it didn't work quite well. And now my trauma colleagues said to me, actually, we're seeing one of these patients every day with a little bit of a sore wrist in these clinics. You know, we see one a day. We're not very good at it. We don't really know what's going on. We're not hand specialists. We can't make the diagnosis. Can you sort it out? So we went back and thought, well, what could we do differently? NICE says two things about this injury. It says you should have early expert review. So away from the sickest for the thickest. It said you should consider early MRI. So they were the basis of our pathway. So we introduced this new algorithm. This is the first part of it. Patients who present with a suspected scaphoid injury, if you have 3 positive signs, and the signs are very straightforward, tenderness over the anatomical snuff box, tenderness over the scaphoid tubercle, and pain telescoping the thumb. If you have any of those signs are significantly positive, particularly the first 2, you should discuss the patient with a senior to get the senior review and order scaphoid x-rays. The reason for the senior discussion there is that you don't want everyone getting scaphoid x-rays. If you get an x-ray, you're almost committed to your treatment pathway. The expert, we put the ED seniors there. Now, we've now changed that because we realise we've got a much better expert group. And they're nurses. Most of this work is now done by emergency nurse practitioners who manage virtually all of these patients. Fractures seen, they're managed in the orange and red group. Fracture not seen, we book an MRI then, the patient goes home and has their MRI. It's a very straightforward pathway, and it's been in process for about a year now, and I'll show you some of the figures from the first few months and a little bit about the first year. But first of all, let's look at some of the x-rays to show you how difficult this is. And this comes a little bit back to what Alex is saying about machine reporting. I'll be quite happy if we had machine reporting of these films, because we're crap at it. The radiologists are crap at it, at reporting them. I'll be honest, you know, because I know, because I've seen the MRI results afterwards. And you actually, looking at an x-ray, getting a report really means relatively little. So that's one film. This is a scaphoid. See, it looks quite nice here. Perhaps a suggestion, this was reported as normal. This is a bit of the cubicle on the side. Perhaps a suggestion there's something going on there. Reported as normal, but when you see the MRI, the cubicle is off and there's all this soft tissue swelling and marrow edema there. Not that important injury. That injury would heal quite well. But it wouldn't have been spotted in the old system. This is another one. Beautiful looking scaphoid, looks smooth, looks probably normal. Was reported as normal by both us and the radiologists. But if you look at it a little bit closer, just down this bottom bit here, you can see maybe there's a line there, retrospectoscope. And the retrospectoscope shows, if you look at it there, this is just a big fracture through a bit of the scaphoid that you would not expect. Significant injury, because that may well get avascular necrosis, a useless hand. And there it is on the CT, which our hand surgeons, Chris Little and his group, used to monitor healing a few weeks later, showing the fracture quite clearly at the base of the scaphoid. This one perhaps I think is the most worrying because it looks entirely normal, and I would assure you that 100% of machines, 100% of people would report that as normal, and yet there's the MRI, which shows the fracture through the waist of the scaphoid, very significant injury. If this isn't treated very, very carefully, the patient could end up with a useless wrist. So that's why we're doing it. That's why we need this investigation. That's why we need to get the right group having this investigation. An ED is like a Harry Potter sorting hat. That's all we do. We sort patients out. We drop them into the right paths. And hopefully we treat most of them, 78% of them, and get them home without any follow-up. So this is our first 50 patients. We analysed this before, and we thought we'd get about one a day, and we were right. 47 days, we had 50 patients. Male-female split was about half. Most of them were correct in the pathway. When we started, we were putting a few too many in, so we've corrected that. This is about what I was talking about x-rays. We thought about 80% of the x-rays were negative, as did the radiology, but they weren't the same 80%. There was only 82% agreement. So actually reporting, really doesn't mean anything. If anyone thinks it's normal, though, the patient goes on to get an MRI. So this fails safe. If anyone thinks something's abnormal, if we think it's abnormal, the patient goes straight into a fracture clinic, so it gets followed up, so it fails safe. If radiology thinks it's normal, but we don't, well, anyway, the patient's already gone to a fracture clinic, so it always fails safe. But this is showing you actually reporting doesn't have much value in this injury because it's not a very good investigation. So 76% of these first 50 patients ended up having an MRI. The rest of them, they weren't correctly in the pathway, or they had a fracture of the scaphoid already spotted, and so would go straight into the fracture clinic, a hand clinic, or they had an injury of another bone that went straight into a fracture clinic. Of those group, the 76%, so probably the 35 patients who had the MRI, a few don't have it. It's because they say, and we contact all of these, I'm actually better now. And so before they got the MRI, they said, they're better. We've written to them and said, if you've got any ongoing symptoms, you must come back. This is the slide that I'm most proud of because it shows how effective this sorting is. 64% had the MRI. 70% of our patients have got a true radiological injury. So that's quite a high pickup rate, isn't it, compared with most scans that people do. And of those, nearly 30% have the diagnosis that we're looking for, scaphoid fracture. My managers are keen on this, that none of the patients come back to us. Half of them go to the hand clinic. A few go to fracture clinic because they've got other injuries. And about almost a third go straight from MRI and don't come back to the hospital at all. So they come back once for their MRI, and actually what happens from the MRI is all the MRI results are reviewed by a hand specialist, one of our hand physio teams. If the MRI is normal, they phone the patient up and discharge them. So they don't touch us again. If it shows a fracture, they're brought back to a hand clinic. So 40% of this group of patients don't come back at all. So it's much more effective use of our resource. There isn't a big wait for MRI. It's only 4 days, and 6 days the patient knows their diagnosis. So this is what Alex was saying. We're bringing back the diagnostics to the place they should be. We're making it timely. We're improving patient care. And actually, we've done this with what cost? No cost. There's been no funding. Nothing else has happened. We've just changed. We've probably added, well, we have added a slight MRI burden, but we've decreased the clinic burden across the organisation. First year, I'm just looking at the first year's figures. There's lots of other interesting stuff. We're picking up an enormous amount of other injuries, which we don't know are significant or not at the moment. We're going to probably change our protocols at the high end, the high age group, because the elderly don't get this injury. The people less than 10 don't get this injury, so we probably need different protocols for that. And we're still at roughly the same numbers, so we're probably getting just about less than 1 a day and roughly 5 MRIs a week. It's always good to get some feedback. So this was an anaesthetic colleague from the trust who came in with this injury. And you need your wrist to sort of do things as an anaesthetist, don't you? So he was able to be reassured that he could go back to work. So taking appropriate investigations, doing them at the right time, sorting patients, it can work. Any questions?
Fantastic. So is the treatment any different? I mean, you're saying people were just putting off review for 14 days. Are you just avoiding that?
What we do now is, whilst the patient is awaiting the MRI, which is average is 4 or 5 days, they get put in a few, just in a splint. And so if they get a confirmed fracture off the X-ray, they go straight into a scaphoid cast and then straight onto a hand clinic. If we just can't see it, if you have a normal X-ray, they get in a splint for 5 days and then they have their MRI. Following the MRI, if it's negative, they come out of the splint and they're mobilised. So they're mobilised, 8-9 days earlier, which is better for them. The other ones go straight onto a fracture clinic or a hand clinic where they get put in a scaphoid cast. Chris Little and Ed, my hand surgeon colleague, then manages these. They are managed in a cast. They have serial CTs to look for the healing of the waist of the scaphoid, and then some that don't heal go on and they need a screw put in.
Brilliant presentation. Can I ask a quick question? If the best diagnostic modality is MR, with no risk, MR has no risk really, apart from the ability to line a scan with your arm and having availability. Is there an argument to say that the kind of best policy would be just to do an MR on all these patients with risk? And I understand there's risks to the trust in terms of how to do that, but would that be something that, if it was me, from what you said, I just want an MR?
I think that's a really good question, thanks. I agree. We had Ed Sullen, my radiology colleague, has been fantastic in supporting this process. He had some doubt originally about whether we would pick up false injuries by MRIing too early. So our original policy was always, when we first started, was to put a delay of 48 hours in before the MRI. Actually, by mistake, a few got MRIs on day 1 or day 2, and the injuries were picked up, or no injury was picked up. So that is false. So we've already proved that that is false. So yes, you can MRI from moment one. X-rays are such a cheap investigation. I doubt whether we should get rid of the plain X-ray because you could pick up other things on it. But perhaps the scaphoid X-ray is as I've shown, it's not really. It was the best we had 20 years ago, but it's no good. So perhaps it would be just wrist X-rays, which would show most of the wrist fractures. And then if you suspect the MR, I would love someone to buy a small parts MRI for the front door. That, to me, is the future, and that's where we'll be in another 10, 20 years. Thank you very much.
Hello, I'm Lois Brand, and I'm going to spend 10 minutes just talking to you about a work in progress, actually. This isn't the finished article like Phil's. This is a work in progress, and I became interested in the management of elderly chest trauma a couple of years ago when we had a series of really quite significant cases which were missed, either because of our lack of care in clinically assessing the patients or our lack of adequate imaging, or a combination of both. And one of those was the Syria, unfortunately. So this is in the context of what we're understanding nationally as a changing face of major trauma. So these are admissions in the last year to the trauma centre here, and the green people are the ones who have an injury severity score of greater than 15 and so classified as major trauma. And you'll see that over 40% of those are in the age group 65 plus. So what was originally sort of perceived to be a problem of younger, particularly male patients caused by high energy RTCs mainly, actually major trauma is now predominantly a disease of the older individual. And most of these major trauma patients are actually getting their trauma from a fall from standing height. So you can see from this graph here, the older you get, the more likely your trauma is to be sustained by a fall of less than 2 meters. Comfortingly, the older you get, the less likely you are to be shot or stabbed. And this causes a problem for us, as you can see as you digest this slide, that our triage system, our pre-hospital triage system, is set up to very accurately identify those people who need a trauma team at the front door and need to be assessed early. We're very good at picking up major trauma in patients in a younger age group, but we are not good at picking up major trauma in people who are older. When we think about the number of people who come into our emergency departments here in the JR and also across at the Horton, we see about 100 older falls a week. And of those, a very tiny number will have sustained major trauma. We are not good at picking those up. And that's because of comorbidities, particularly if they're cognitively impaired, it's more difficult. It's because of the fact that they might be on beta blockers and so don't mount a tachycardic response to their hemorrhage. It's because they've got smaller brains encased within their cranium, and when they have blood in there, they don't always show that so much as a younger brain might, which might be more quickly squashed. So lots of reasons why we find it very difficult to pick these people up. And as a result of this, we manage these patients differently. Now, arguably, we should be managing these patients differently. They probably don't need a full trauma team response, but they do need to be identified early and managed appropriately. Tarn have recognised that this is a significant problem because the way that we've set up our major trauma response across the country is really targeted to the lower age group and high energy trauma. But this is now a big problem with our older patients. So they looked at what we were currently doing across the UK and produced this report in 2017 and found that the older trauma patient is less likely to come to the major trauma centre and so potentially denied access to the expertise there. more likely to be treated by a junior doctor, because when these fallers come in, they just next to be seen by the junior doctor, who probably will not realise that these patients have got to be looked at very, very carefully in order to rule out major trauma. More likely to have delays to investigations, less likely to have surgery, more likely to die. However, in the survivors, there's only a little bit more disability than in younger patients. So specifically thinking about imaging in chest trauma in the older patients, we know that plain films are useless when we're dealing with major trauma, so we don't even bother with them. If we have a trauma call, we're seeing the patient in resus and they've been hit by a bus, we might do a very quick chest and pelvic X-ray that's not going to slow us down at all, actually in resus, but then we will move very quickly once the patient is stabilised and within 30 minutes to doing a whole body CT scan, because we know that's the only way we're going to pick up significant injury. However, as we've already said, the older patients, there are lots and lots of them, and they're sustaining these traumas by a low-force mechanism, and we need to find the needle in the haystack. Chest X-rays are, we know, inadequate to pick up a lot of these injuries. So we were left with a real problem that we couldn't ask radiology to pick up the slack here and scan everybody, and we needed to try and find a way of working out how to identify the patients who needed cross-sectional imaging without breaking the radiology department. So the first thing that we did was identify some key questions, and we went to the literature. So the first question was, how does chest trauma in the elderly differ from that of the general adult population? And the literature is quite clear on this. There were three key papers that we focused on, it says that elderly patients who sustain blunt chest trauma with rib fractures have twice the mortality and thoracic morbidity of younger patients with similar injuries. And for each additional rib fracture in the elderly, mortality increases by nearly 20%. And the risk of pneumonia by nearly 30%. And elderly patients are prone to complications with rib fractures, even when minor trauma was the cause. So does CT identify clinically significant injury missed on chest X-ray? This was more difficult to answer because there were no papers that looked specifically at the older patients, but looking at a couple of papers that did address this question in adults, it was clear that CT detected clinically significant injuries, and up to 50% of rib fractures are missed on plain X-ray. Does early identification of these injuries positively impact the clinical course? And this was a key question to answer for our radiology colleagues who didn't want to be doing these CTs just so that we could get an accurate diagnosis, but it wouldn't actually change the management. And there were 4 papers that we looked at here, 1 prospective, 2 retrospective, and a literature review that looked at this question, and all concluded that early identification and aggressive pain management, physiotherapy, and where appropriate surgical fixation improves morbidity and mortality in these elderly patients. The final question, what identifies patients who would benefit from this CT chest, is, as you would imagine, the most difficult question to answer. There were 2 papers that came some way to addressing this, but it wasn't terribly clear how we were going to be able to sift out this needle in the haystack. So we did our best from taking what we found in the literature to try and come up with a clinical decision tool to aid our clinicians in the ED to decide who should get a scan. After reading the literature and having this series of misses, I just wanted everybody who fell over, who had got chest tenderness, to have a CT, but that was clearly going to be a non-starter with the radiologists, who are very overwhelmed already by the amount of work that they're doing for us. So we put together this guideline and have since then reviewed the guideline and seen what the effect has been. Once we've done the CT on the patient and identified the injuries in the chest wall, it's a plain CT we use, we don't use contrast CT for these patients, we can then calculate the battle score, which then informs their onward management. So the battle score is it's been what's the word? What's the word, Alex? Beginning with R. I'll come back to that anyway. It's the battle score is well recognised as a tool to help stratify risk in patients with chest wall injury. And you'll see from here that we have a guideline which suggests that those with minor injuries can go home. Those with a moderate battle score can be admitted for pain relief and mobilisation under the medical team. And anybody with a battle score of 21 or more will be discussed with the thoracic team. And there is some flexibility here. Those who are not needing fixation and who the cardiothoracic team think can be managed under the medical team can then be discussed with the medical team and managed through them. And that's often the best pathway for those who are not going to have surgical fixation. So these are some of our numbers. We looked at 6 months of data before we implemented the guideline and 6 months after. Those of you who are still conscious will notice that the numbers before are significantly lower than the numbers after. I don't think that represents the fact that we had more patients during that 6 months. It's just unfortunate that in between the pre and the post, we had a complete change in the way that we recorded data about patients' diagnosis within the department, and that was beyond our control. It does mean, however, that these sorts of things are now much easier to look at, but it means that it's difficult to compare accurately pre and post. But what you can glean from here is that a greater proportion of patients had a CT scan afterwards than before, but it's not a huge increase. You'll also see in the post numbers that quite a few had a chest x-ray first, and that's not what we would have wanted to happen, because that's probably not really very useful. I think that when the patients need an image, then they need CT here. We're not adding anything by doing the chest x-ray, but you'll see that it's actually quite useful. We wouldn't have been able to put that through ethics to say we want everybody to have a chest x-ray and a CT so we can compare whether the CT really is picking up something that's more useful. But that little grey wedge there on the right is actually quite useful for us, as it turns out. So of the patients who had a CT, I think the numbers was 65 post-implementation, you will see that out of those 65, only 9 of those were normal. So we've got a massively high pickup rate, which makes me feel very anxious that we are missing significant patients. None of the patients in the 6-month period came back with something related that weren't picked up on CT, but these are small numbers. So you can see we're picking up an enormous amount of chest pathology. This is the slide that I mentioned where these 27 patients who happened to have both chest x-ray and CT, we compared the findings of the two. And as you can see here, we are picking up significant injuries on the CT, which are being missed on the x-ray. The other thing which I think is important is that when we looked at the data retrospectively and looked at the number who met the criteria on the guideline, I mean, it's obviously difficult to be accurate because you're looking back at the notes rather than seeing the patient in front of you. But looking back, of the 62 people who met the criteria for scan, 2/3 of those were scanned. And of the 65 patients who didn't meet the criteria for a scan, 1/3 of those were scanned anyway, and of those, about a half, we found significant injury in, which makes me think, again, we need to rethink this guideline and lower the threshold even more for scanning in this group of patients. So looking forward, we're going to continue reviewing the data, further developing the imaging guideline. Ongoing education of our clinical staff is obviously really, really important. Unless you undress these people and go over them with a fine-tooth comb, you are going to miss significant injury. And ongoing review and development of the inpatient pathway is obviously key to this as well. Okay, shall I take questions at the end after yours? Thank you very much.
Thanks, Lois. Okay, so I'm going to just give you a quick, before we take some questions of these at the end, I'm just going to run you through very quickly through 2 further projects that are both imaging related, both of which actually are in collaboration with surgical colleagues. So the first of these is a small pilot RCT that we've put together, and this is based around imaging pathways in acute gallstone or suspected acute gallstone presentation. So no news to anyone here that gallstone disease is really common. There's a prevalence of around 15% in the population in the developed world. There's the 3 sort of key imaging modalities. So ultrasound, which is is relatively cheap out of the 3, but very operator dependent, a lot of noise and signal ratio, and is often quite insensitive to picking up some of the gallstones themselves and any sort of issues with the common bile duct. There's ERCP, which is obviously very invasive and expensive, tends to require an admission or at least a day case. And again, quite a lot of interoperator variability. And then the current gold standard is MRCP, which is has very good sort of sensitivity and specificity for gallstone disease and the complications around it. It's non-invasive, considered expensive, but actually coming down in price. And in most of the HES stage, it's actually a similar cost to ultrasound. But again, is somewhat qualitative, and it relies a lot on the judgment of a radiologist to say whether the bile ducts are dilated or not. So one of the companies working in Oxford is Perspectum, where we have a sort of research relationship, and they came up with an algorithm for interpreting MRCPs quantitatively. This has been used in things like primary sclerosing cholangitis, fatty liver disease, looking at fibrosis. One of the perhaps the sort of more marginal possibilities, though, is to look at the biliary tree itself and actually find some quantitative imaging as an objective finding. And you get images a lot like this, particularly the one on the end. You can see the sort of red hot spots, and the different colours reflect different diameters. And it's actually possible to get a score for an overall dilatation or otherwise of the biliary tree and predict or sort of detect obstruction. Well, why is this relevant to us? Well, we became interested in pathways for these patients in terms of imaging, and most people realise that the standard sort of test of choice in OUH has been the ultrasound scan. The idea is that you should be able to scan people fairly quickly and cheaply, discharge, and make a decision on whether or not they need an MRI scan if there's any suspicion of any obstruction further up, or if the ultrasound is not sufficient to give you the full diagnostic picture. And we ran a 6-week audit. Now, this is a disclaimer, this is about 3 years ago, and things have shifted quite considerably with the advent of ambulatory care in the SEU. But broadly speaking, you can see here there's about half out of sort of 36 patients, so roughly, one a day, give or take. 27 of them received ultrasound, and of these, actually 14, so over half of them actually went on to have an MRI anyway. And the point about this is, obviously, there's not much value in doing an ultrasound in similar vein to the X-rays and scaphoid. If you're then going to have to go on and do an MRI anyway, why not just do the MRI? And this, when you add in the time to reports and the admission times and all the consequent length of stay about this, well, it becomes quite a big economic problem. So again, the times of these have probably improved over the last couple of years, but not dramatically. It was about 24 hours to get an ultrasound report, and up to about 40 hours. And these are mean figures to get an MRI report. And this is a big delay for patients in terms of complications and outcomes. There's also just a big admission burden. So with putting our heads together collectively, so between A&E, Zahir Sinawaller in surgery, Adam Bailey in gastroenterology, and Helen Munger with radiology, and supported by the Perspective Diagnostics, we put together a pilot RCT, which is ongoing at the moment. It's very small, just 64 patients, split 50-50 between direct MRCP, so within 24 hours, and standard care, which is whatever the clinician feels is needed. So this is ongoing as we speak in ED and SEU. So what's tricky here in these kind of things is how you decide what your primary outcome is, because of course the length of stay may actually be increased by an MRI if you find a complication that needs a lap chole or that needs an ERCP. So we came up with this sort of composite endpoint, which is the cost of final diagnostic report. So the cost of admission up to that point at which you get a diagnostic report, which then doesn't change, so that it was sufficient to allow discharge. And we're looking at some secondary outcomes as well, so cost of admission, patient-reported outcomes. And perhaps one of the more interesting drivers for this is the exploratory outcomes. All the patients are consented to use their images, anonymised images, to develop the algorithm for looking at the biliary tree itself. So the outcome is also whether we can perhaps develop a sort of validated quantitative measure of looking at the biliary tree reports. Essentially, this is the inclusion criteria. So it's adult patients, suspected gallstone or biliary disease with acute abdominal pain, and just anything mildly deranged. All of these are about a 10% increase in the LFTs. So fairly pragmatic. At the moment, we have about 14 patients recruited, and we're looking to complete in spring next year. And hopefully we'll be able to present a little bit more then. So that's one of the projects I wanted to talk to you about, just because I'm aware we're zipping through for time. I'll talk to you quickly about the next one, which is the GE Critical Care Suite. And this basically is a mobile X-ray machine with embedded AI tech, and again, the evaluation is ongoing now in OUH as we speak. And this has two key capabilities. One is image optimization, and one is picking up pneumothoraces. And our prevalence in the ED is fairly low, actually. So it's 5 to 7 for about 1,000, so 10,000 admissions per traumatic or iatrogenic. And in primary spontaneous, it's about 8.6. So it's fairly low, but it's present and there. And of course, this excludes thoracic surgery patients who virtually all have a pneumothorax when you open the chest. This is what we tend to be faced with in the ED. And as you can see, if we're looking for a pneumothorax, we might be able to spot this here, but it's not something that leaps out of you. And certainly if you're a junior reporter or someone in a hurry or quite distracted, it's not always an easy one to spot. And it's a frequent cause of a phone call in our sort of subsequent reporting. And of course, this is actually what we tend to see in A&E, which is a chest X-ray slumped over with all the other things going on, and there again, there's a pneumothorax. So this kind of illustrates the point of where AI could fit in terms of detection, because actually, for the best will in the world, it's fairly tricky, and it's certainly tricky if you're not suspecting it in the first place. And this is the critical care suite. So this, you can see here, this is the X-ray. It comes up with a point of care image. And this has already been put together in the States. So they've done their diagnostics. The stats are kind of interesting. So over there, the ones I picked out, the negative predictive value is pretty good. So it's pretty good at telling you if there isn't one, which is actually, for me as an A&E doctor, is actually the most useful thing. I want to know whether it's reliable. The positive predictive value, considerably less so. But it's possible to tweak the sensitivity of it, of the various configurable thresholds, depending on how concerned you are. So this allows you to change depending on which clinical area you work in. It also has this intelligent auto-rotate. So this is to avoid the kind of slumped image. It enables the tech to interpret sort of standardized X-ray film, and it also improves it for the clinicians. So we're running a market evaluation in this at the moment, and this is in collaboration with Elizabeth Belcher in Cardiothoracics and Fergus and the NCME. The machines are already in place and are collecting images, and we're looking at completing this in the next few weeks. Following on from this, we've put in ethics for perhaps the key question, which is it any good in terms of detecting pneumothorax over and above clinicians? So this is going to run a subgroup analysis where we'll look at different groups of clinicians, so ICU docs, ED docs, radiologists, radiographers, nurses, and at different levels of seniority, and just compare the algorithms against them, see where it sits. And we'll look to complete that within about 12 months. Now, this is pretty small fry stuff, as you appreciate, but and perhaps pneumothorax wouldn't be the most immediate thing that would grab everyone's attention here, but the point of this really, I guess, is proof of principle that this can be fairly quickly updated. The algorithms are already in process for pneumoperitoneum, rib fractures, all these things that are quite easy to miss on chest X-rays. And this is, again, we look to replicate this for various other pathologies. And so that's it in terms of the presentation. So it's 4 projects, all very different arenas as far as emergency medicines are concerned, but all involving the same kind of principles about bringing expensive tech earlier in the pathway to have an overall cost benefit, and with some implications for where technology might fit in. And you're likely to be seeing many more of these. Thanks very much, and any questions?